This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2019, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist and asthma educator and Associate Executive Director at the AARC. I welcome you to today's presentation, Silver-Coated Endotracheal Tubes Cleaned with a Mechanism for Secretion Removal. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Ms. Donna Tanner. Ms. Tanner is a registered respiratory therapist and adult critical care specialist at the Cleveland Clinic in Cleveland, Ohio, where she is the education coordinator for Cardiothoracic Anesthesia Respiratory Therapy Department. She is active with the AARC and was named the AARC Adult Acute Care Specialty Practitioner of the Year in 2017. Ms. Tanner has no relationship to disclose. I disclose that I am a paid employee of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Donna, welcome to the program.
Welcome, everyone, and thanks for joining us this afternoon. Thank you to Shauna and the AARC for the opportunity to present this month's JournalCast of silver-coated endotracheal tubes cleaned with a mechanism for secretion removal. So I think we should start with some background. And I think it's fair to go back to the NASCENT trial from 2008. This was a prospective, randomized, multi-center, single-blind controlled study, and it looked to determine if the silver-coated endotracheal tubes would reduce the incidence of VAP. They looked at patients mechanically ventilated for over 24 hours, and they concluded that the silver-coated endotracheal tubes did slightly decrease the incidence of early onset of VAP, and it was about 4.8 to 7.5% when compared to that of an uncoated endotracheal tube. So here we have the 2010 article published in Chest, retrospectively reviewed the patients that were in the NASCENT trial that developed VAP. They determined causes of death in the VAP were due to potentially multi-drug resistant bacteria. They concluded to validate NASCENT trial to hold true that the silver-coated endotracheal tubes were associated with decreased mortality in those patients that developed VAP. Then comes the 2015 Cochrane review. In the abstract, they describe the mechanism of action for these silver-coated endotracheal tubes, that they slowly release silver cations and that they have a strong antimicrobial effect, and this could be effective in VAP prevention in these patients ventilated over 24 hours. However, they concluded that the review provides limited evidence in the silver-coated endotracheal tubes, reducing the risk of VAP, especially during the first 10 days of mechanical ventilation. So let's talk about what we already know. We know that silver-coated endotracheal tubes may contribute to the decrease of ventilator-associated pneumonia, that most related studies have shown this within the first 10 days of intubation, and those intubated less than 10 days. What really decreases VAP, other than liberation, of course, is controlling colonization and biofilm formation. The silver-coated endotracheal tubes are less likely to have mucus obstructing the lumen of the tube, and the only other endotracheal tube associated with decreasing ventilator-associated pneumonia was subglottic suction. However, there isn't enough evidence comparing these side by side to state superiority of one over the other. So looking at Peroni's study, they took critically ill patients who were emergently intubated with a silver-coated endotracheal tube. They looked to see if keeping the surface of that tube free from biofilm and secretions would improve the effectiveness of the tube, and to keep the silver-coated endotracheal tube, quote, clean or free from the biofilm and the secretions, they used an endotracheal tube cleaning device, and in this study it was called the EndoClear. So just briefly, let's review the mechanisms of actions of the silver-coated endotracheal tube just to set the stage of Perrone's study. The study used the Agento tube, and I apologize if I pronounce that incorrectly. The release of the ions attack the microorganisms that are present in the contaminated secretions, and you can see on the slide that the ions actually elude the distal to the endotracheal tube. The steady release of the silver ions penetrate and then kill the bacteria. So now we look at the endotracheal tube cleaning device that we use here, which is the EndoClear. In April of 2017, there was a study published in the Surgical Infection Journal that validated the effectiveness of the scrubbing device. However, a few months later, several editorials and commentaries questioned the accuracy of the study. Just to give you an idea of what Perrone and colleagues did, you can see that the EndoClear is there inside the endotracheal tube and how it's actually scrubbing the side of the tube in a sense. Okay, so looking directly at the study, what the authors aimed to do was to evaluate the efficacy of this specific endotracheal tube device with the silver-coated endotracheal tube. Their primary endpoint was the detection of a difference in the microbial colonization of the coated endotracheal tubes in their treatment group, which received not only the cleaning device, but also the endotracheal tube. Here, they're looking to prove that in mechanically ventilated patients, the periodic removal of secretions with the cleaning device would increase the antimicrobial properties, therefore reducing bacterial colonization. Moving to the methods section of the study. So this is an interventional clinical trial. The actual enrollment was 39 participants, 20 in the control group and 19 in the treatment group. It is a randomized study. It was a single center study out of Mass General, and it was IRB approved. All patients who required in-hospital emergency airways were intubated with a 7.0 silver-coated endotracheal tube. This was an adult study. They expected to remain intubated for at least 48 hours, but they could be enrolled in the study within 24 hours after intubation. Once they were selected, they were randomized through a sealed envelopes of a 1-to-1 ratio. Your control group received the standard airway care, the silver-coated endotracheal tube with blind suctioning. Your treatment group received the blind suctioning, silver-coated endotracheal tube, and the cleaning maneuver with the EndoClear Q8. Here you can see that 40 patients were assessed for enrollment. One was dismissed for inability to obtain consent, so 39 subjects were actually enrolled. The control group contains 20 patients. The treatment group or intervention group had 19. Both groups dropped to about 18, and they obtained 29 samples from here. Table 1 lays out the description of the study population. Ages of subjects ranged in early to mid-60s, with the standard deviations listed there. This control group was 53% female, and you can see the numbers for those admitted to MICU, surgical, and emergent cases. The reasons for intubation are listed, and airway protection being the main source here. Interesting, though, there's only one current smoker in the entire group. 73% of the study population had a diagnosis of COPD, asthma, or bronchiectasis, and the duration of intubation was give or take 6.9 days, and the treatment group was slightly less. All right, so all subjects had the silver-coated endotracheal tube, and the treatment group received the single pass of the EndoClear Q8 hours. Both groups received the Mass General VAP bundle, and both groups had their endotracheal tubes, the cuffs checked Q8 to maintain 25 centimeters. Immediately prior to extubation, samples were obtained. The ET tubes were collected, and they had clamped the proximal end below the connector, and then also clamped the distal end right above the Murphy's eye. Endotracheal tubes were placed in sterile bags, sent off for processing and analysis. So processing, obviously a sterile environment. They sliced into the endotracheal tube just above the eye and removed a 0.5 centimeter slice. Cultured these for analysis. They then filled the endotracheal tubes with 10 cc's of the solution, and this was done for silver ion activation. The biofilm was collected and sealed. They were placed in a bath for 90 seconds, vortex for 30 seconds, and then sent off for culture. They then took 10 endotracheal tubes, 5 from each group, and did an additional 0.5 centimeter slice. So sample size and statistical analysis. Endpoint of the study is to determine if there was a reduction in the endotracheal tube microbial colonization using the silver-coated endotracheal tubes with the cleaning maneuver. And what the authors expected to see was that the tubes in the treatment group would show an average reduction of 0.5 logs compared to those without the endoclear. And they used logs in this because of the large number of bacteria that they needed to count. So results. So review the sample size. Again, we had 39 subjects expected to be ventilated over 48 hours, 36 endotracheal tubes, 18 from each group, 29 tracheal samples, 15 control, 14 treatment were collected. All the endotracheal tubes positive for bacterial colonization. Cleaning maneuvers did not reduce any microbial load. There was a downward trend in biofilm in the treatment group that had used the endoclear. No significant differences observed in tracheal aspirates. No significant differences in gram-positive organisms, gram-negative organisms, or yeast in the tracheal tubes or aspirates. So looking at table 2 and 3 from the study, we're looking at the colonization of the endotracheal tubes versus the secretions. So at first glance, the treatment group has a significant reduction in biofilm, but the standard deviation is over 157 here. So it brings the p-value down to like 0.09. Looking at the colonized tubes, again, 15 control, 9 treatment group, there's no significant difference in the organisms or the loads. So analyzing the tracheal secretions, it follows suit to show no significant variances against the groups. Here we look at figure 2 from the study. 2A, 9 tubes from the control group, 7 from the treatment that showed multiple species of bacterial growth with an average of an isolated species per tube, 1.6 control, 1.1 treatment. And then looking at slide 2B, it's the number of tracheal secretions with multiple microbial species per sample, and it was fairly similar between the groups, and the average number of species was similar. So total microbial load was increased in the airway, but it did not differ between the groups at all. So what do these findings mean? It shows that this randomized controlled trial showed that despite the efforts to remove the secretions from the lumen of the silver-coated endotracheal tube, both bacterial and fungus were present in 50% of the tubes. And how does this really impact our practice? We all have the speculation of silent aspiration of secretions past the cuff and the need for continuous pressure regulation and the subglottic suction devices, but it's still doubtful that that would have changed any of the results at that point. And what do these findings, how do these findings related to previous findings from other studies? There are no studies that demonstrate prevention of pathogenic bacterial colonization in the endotracheal tubes. We did have some study limitations here and definitely sample size. The authors looked to detect a 0.5 log reduction, which would have been 50% of colonization. So they actually asked if they would have detected a lower reduction rate had they had a larger sample size, if that would have changed or skewed the results at all. What additional work is needed in this area? They're going to definitely need more experimental studies to explore the mechanisms of formation of pneumonia in the intubated patients and whether cleaning the endotracheal tubes to prevent biofilm would actually decrease the colonization in the lower respiratory tract. So the editorial by Rush and colleagues responded by commending Peroni for the study that was performed. Rush recognized that the treatment group had decreased biofilm deposition through cleaning, but was left without statistical significance, and also mentioned that the limitation of the study size, had played some significance in there as well. Also to be noted, the authors had targeted biofilm prevention only and did not look at, again, the microaspiration of gastric or pharyngeal secretions. Expressed interest in biofilm prevention as the modulation of host response, and that future research is needed. It's definitely warranted in intubated critically ill patients, that there is a need for a large randomized controlled trial, and whether the combination of using the silver-coated endotracheal tubes and devices are superior to the gold standards of VAP prevention. And worth mentioning, there is no true gold standard criteria to clearly diagnosing ventilator-associated pneumonia. So the conclusions of the study and the take-home message here is the fact that endotracheal tubes, silver-coated endotracheal tubes, are already known to significantly decrease the incidence of ventilator-associated pneumonia and the time to the VAP occurrence. However, these tubes are shown to be beneficial only during the first 10 days of mechanical ventilation. VAP bundles, we all have them. We all use them. They may slightly, they differ between organization, but they may need to be enhanced and incorporate endotracheal tube cuff pressure monitors and some subglottic suction devices. And that pretty much wraps up the study, and if anyone has any questions, I'd be happy to take them.
Thank you, Donna. If we could, I'm going to go back in your presentation to this picture of the silver-coated endotracheal tube.
Sure.
With today's focus, obviously, on cost containment and making sure not only we keep our patients safe and healthy, but also that we are frugal with the dollars we have to spend. Some folks may not be familiar with the silver-coated endotracheal tube. Do you have much experience with this tube?
I have a little experience. We had trialed them, and with any piece of equipment, there's always pros and cons. One of the largest cons on this side is that it is listed as MRI variable. So if you are in an institution that does a lot of MRIs, you may find that you are in a little quandary at times if your patient is wanting to go in there. Also, cost containment-wise, these are very expensive tubes versus our normal endotracheal tubes that we are seeing. And I don't know if anyone else out there has done actual, controlled trials from the silver tubes to their endotracheal tubes. We had not. We had trialed these to see if we had liked them, and it wasn't anything that we had decided to move forward to, and it was all based on cost at that point.
So in your experience with these tubes, do they operate any different than a regular endotracheal tube? For example, are they more difficult to place? Do they cause injury? Are they stiffer than regular tubes?
We had not heard of any of that from those, the anesthesiologists that were actually placing the tube. They had actually been asked to fill out a survey. It wasn't an overwhelming like of them, but there weren't any patient safety issues with them.
Okay, great. Do you know if there are any real evidence to say, yeah, we should all be using these silver tubes? It's going to absolutely wipe out all of our ventilator-associated pneumonia versus the it could help, it could not help kind of thing. Is there any clear evidence either way?
There isn't. The NASCENT trial that had started out did say that the silver-coated endotracheal tubes did show, a slight decrease in ventilator-associated pneumonia. But again, these are studies always looking at early prevention and only with the first 10 days of mechanically ventilated patients. So there's not going to be anything significant to show after that time.
So that's interesting, and I don't know what the practice is for a lot of different facilities. The more I talk with folks, the more variance I see in practices. But in some facilities, after day 3 or 4 of mechanical ventilation with an endotracheal tube, now we're talking about a tracheostomy tube. So I would imagine that there is a very real possibility that most of our adult patients would not be mechanically ventilated through an endotracheal tube past day 10. In neonates, that's totally different. We tend to keep those babies intubated for quite some time, but so I can see the 10-day. Let's say, though, that we had a patient who was intubated prior or longer than 10 days. Would we need to replace that tube? Or is it still just not effective regardless of whether we're putting a tube in?
Right. It's still, there's not enough evidence to show that would, that it would be effective. But there's also not enough evidence to say that it wouldn't be effective. It needs to be, I think some trials need to be with these to exactly show what happens after day 10 and then, really define the ventilator-associated pneumonia guidelines to find out, of course, was your patient already infected before we got there and everything that had happened previously.
Right. So with these tubes, I would imagine if we, I'm going to bounce around a little bit on your slide deck here, and I'm going to go back to our description of the study population. The age range was pretty tight. Wasn't a whole lot of variance, but do you know if the silver-coated tubes are available in a variety of sizes, or are we pretty limited on where we can use those?
So these tubes for this study, they only use 7.0s. As far as if they are available, I do believe that they are available from a 6.0 to an 8.0.
Okay, great. So it does, but depending on our population, it does perhaps prohibit our use in various spaces.
Correct.
So the move around just a little bit. So to go back to this picture of your silver-coated tube, so the purpose, our problem statement. Let me restart. Our problem statement is that our patient has secretions, and secretions can slip down past the cuff of the endotracheal tube and colonize in the lower airways. So the issue here is that we aren't managing the patient's airways well enough to avoid ventilator-associated pneumonia or ventilator-associated events. Should we be focusing on VAP as that endpoint, or should we be focusing on ventilator-associated events instead?
I think especially in light of the CDC changing the actual definition of ventilator-associated pneumonia to ventilator-associated events, I think that that's a very fair statement. And I think with any of this, and even this study can help us show that maybe what we need to concentrate on is more of the continuous cuff regulation instead of, checking cuffs Q8 hours, where you're actually deflating the air and, watching all those secretions go down into the airways. So there's a lot of room for improvement there, without a doubt.
Absolutely, and it segues a little bit into a question from the audience. The materials that we use for oral care for our patients. Obviously, we want to continue with good oral care, good oral hygiene for our patients while they're unable to do that for themselves. And I wonder, as I think about how we and our nursing colleagues perform oral care and the potential for those materials, of course, to slip down into the trachea if we're not careful, and then Q8, reduce the cuff, check the cuff, whatever we're doing, that potentially slipping into the airways as well. So, there's that kind of an issue. But do we know if any of the compounds we use for oral care could affect the efficacy of the silver tube?
We don't, and we don't even know if it could affect the efficacy of the cuff itself. Nothing has been tested to that point where, especially in light of microaspirations of the secretions, what type of damage we're actually doing when we do oral care for our patients.
So I want to talk now a little bit more about, I'm going to go to your next slide here, about this scraping device.
Yes.
So I will be honest and tell you that I have never seen this in practice. I've seen photos, I've listened to some lectures. So in the picture on the right, we see an endotracheal tube in a clear tracheal model, right? And then we've got the cuff up, so we see that the cuff is inflated. And so the coil that I see inside the endotracheal tube, that is the EndoClear device, right?
Correct.
So I see on the left-hand side, I see the device, the handle and such. So first of all, when we put this particular device inside the endotracheal tube, we have to recognize not only are we forming some sort of airway clearance, but we're occluding it looks like most of the lumen. Is that correct?
That is correct, and we also have to be very cognizant of the airway resistance that we could then, cause on the patient as well, because you're occluding, to scrub that biofilm off, you're inflating that balloon to literally scrub the sides of the endotracheal tube, so that is a temporary occlusion of the tube, which could cause a very, severe, not pleasant experience, especially to the spontaneously breathing patient at that point.
Now, is there a hazard here? And I'm thinking about the physics of inflating these, and I would imagine you insert it, you inflate it, you pull it back, and it scrapes the sides of the tube. Is there the potential that we knock something off down at the end of that tube and it can be aspirated back into the patient's lungs?
Absolutely, yes. Just to look at the device, and I'm sure everyone would agree, it looks like a very barbaric device, and to actually think of the mechanism of, and the way to go down and to scrub that tube, I think they would be very hesitant for a lot of us to even go ahead and to trial that, knowing what we know about endotracheal tubes and, securing the patency of a tube to be able to do that. And just like with anything, I think that, as you do that and there's some secretions, especially above that Murphy's eye, and you're scrubbing it, you do have a very strong potential to go ahead and lodge something in even deeper.
And I would imagine that this is also dependent on the department's risk-benefit analysis of their patient population. If I'm reading this study and I'm thinking to myself, how could I apply this in my clinical environment, then maybe I look around and say, well, I only had, 2 VAEs last year.
Right.
Is it really worth using this device, potentially causing harm to the patient, the amount of training needed, and so forth, to, for basically what I've already identified is a pretty good VAE situation. 2 incidences out of, however many hundreds of patients that I have might not be enough of an incentive for me to, A, spend the money on silver-coated tubes, or B, spend the money on this particular device.
Correct. And we all need to be, fiscally responsible and at least thinking of that at every point. And, of course, none of us want to, encourage or condone the VAP, but we do need to look at, the return on the investment with these devices and the high cost that does come with them.
Now, in this study, they used the EndoClear with the silver-coated endotracheal tubes, but the EndoClear can be used with any kind of endotracheal tube. Is that correct?
That is correct, yes.
Okay. And is this only a device to be used on adults, or do they come in sizes small enough for the pediatric population, or has that not been tested?
I don't believe it's been tested on the pediatric population. When I had done some brief research on this, it looked like it is one size and one size only. So, just from my, personal opinion, I think that this is way too large to be using on, definitely for the children. And I definitely wouldn't use it on a small endotracheal tube. I think personally, I would have a problem trying to put this down a 6.0 endotracheal tube.
Right. So the interventions, and I'm going to come back to this slide here, your method slide. So in this particular study, every single patient had a silver ET tube.
Correct.
And then 20 patients had just the silver tube with the regular VAP bundle at that facility, and then the other 19 had everything exactly the same, except every however often, every 8 hours, they had the cleaning maneuver with a single pass of the EndoClear. Now, with that single pass of the EndoClear, is that traditionally followed up by suctioning?
It is. It didn't lay it out in the study, but the manufacturer guidelines for the EndoClear would be to suction pre and post cleaning of the tube.
Got it. I could see that there might be remnants of whatever you've sloughed off of the endotracheal tube within the tube when you're done. So suctioning afterwards makes sense. So the question was, would the patients have less organisms growing in the tube if they had the EndoClear as well as the silver tube and the VAP bundle? And ultimately we found that no, right?
Correct. There was no significant difference between the two.
So if our only concern with our population is that we need to reduce the microorganisms, doing both of these interventions is not necessary. So that might not be a cost that is justifiable.
Correct. And there's also room for studies to see is there any difference using the EndoClear with our non-silver-coated endotracheal tubes, or is there room to use these with our subglottic suction devices of the endotracheal tubes that do have that? So it opens up. I think the authors did a good job of opening this up for more studies.
And that's a good point. We might not need both of these expensive interventions, but one or the other might be something that could be beneficial to our patients.
Correct.
So the whole point with this particular study was to reduce VAP or VAE. So click over to the discussion, and we'll look at a little bit at the editorial that that the Respiratory Care Journal published.
Mm-hmm.
If someone wanted to reproduce this study and take the lessons learned from these authors and apply it toward a bigger, more effective study, what kinds of interventions would those researchers want to focus on?
I really think that they really need to focus on the fact of increasing enrollment size and doing a very large study at that point. I think our original study from Peroni and friends had really, limited themselves with only having 39 patients in there. And it's very difficult to get results, and, just one, can be a variance of anything at that point. But as far as looking to see what other things that, you can focus on, it would definitely be, the prevention of VAP or VAE and seeing where we can improve on practice at that point.
So I want to go back a little bit to the interventions, and one of our attendees has asked if humidification at BTPS is the best method to reduce biofilm. Can we manipulate our heated humidification to help reduce VAP or VAE?
That's an excellent question. And in this study, there was no mention of how these patients were ventilated at all. There was no mention of HME versus, heated humidity. And that would be something that, we could definitely, the biofilm, is in there and in the tube and does need to be, scrubbed out if you're an EndoClear or cleaning device advocate at that point.
So
mm-hmm.
If we take the EndoClear device at its intention, which is to scrape the inside of the endotracheal tube, could this be used to clear a partially occluded tube rather than extubating the patient and re-intubating them?
That's an excellent question, and I don't know how many of the audience, how many of you have actually used this device. I had seen the device a few times, and I know it wasn't one of my favorites just because it felt flimsy in a sense, and I don't mean any disrespect to, obviously the makers of the device, but I don't know where in that, if it would be actually strong enough to go ahead and clear an occlusion for that versus perhaps using, a bronchoscope or even a traditional suction catheter at that point.
So if I'm thinking about the physics correctly, and again, just to give us a visual to look at while we're talking here, thinking about the physics of this device, simply putting it through the inner lumen of the tube would knock anything sticky off of the sides by itself, just like the suction catheter. So really it would be for something that was maybe a little extra thick or adherent that a suction catheter might not pick up.
Exactly. So I think this device itself would do a good job of getting the things on the side that the suction catheter could not or will not. And especially, and the true mechanism of action of this is, to scrub those sides out and to bring it back out.
Right. So, the researchers' intent, of course, and we'll come back here to the intent of the study. So the whole point of this study was to figure out whether or not we could reduce the incidence of VAP for this population by having two different interventions. So keeping that endotracheal tube free from the biofilm and secretions could improve the effectiveness of the silver-coated tube. So do we have evidence that says if the inside of the silver-coated tube is, I don't know an appropriate word to use here, coated with debris or secretions, that reduces the effectiveness of the tube?
We don't have any evidence on silver-tracheal endotracheal tubes, to actually validate that, no.
It seems logical, though, that if the tube is coated with secretions or debris or whatever, that the effectiveness of the material of the tube is reduced. So it makes sense.
It does.
So it's certainly, the research question is certainly a logical question. Unfortunately, we didn't see enough change, and we'll go back here to this slide of the figures showing how well the samples worked, how well the different groups worked. We just don't have enough evidence to say that using both of these devices would make an appreciable differences.
Correct.
So going forward and thinking about ventilator-associated pneumonia, ventilator-associated events, patent airways, and so forth, what are some takeaways that our practitioners can go back to their clinic environment and take home some good practices to help reduce or prevent VAP or VAE in their facility?
I think one thing that we should all be very conscious of is the fact that we do have some microaspiration of contents. We do need to really make sure that we are using our VAP bundles, that we aren't 100% sure that there's any one cure-all for any of this. It's we've shown that silver-coated endotracheal tubes alone don't work, that the endotracheal tube scrubbing devices themselves don't work, and the combination of the two. So it's just for us doing our best practices of the things that we know, the keeping the head of the bed at 30%, the quick liberation of mechanical ventilation, maybe the idea of having a non-invasive to not even intubate that patient, to even give us that part where we have to think about a VAP bundle. So I think there's a lot of things that we can do, and I think we do it every single day. I just think we need to make conscious efforts of, getting those patients liberated and off the vent as soon as possible.
That's a really great point. A lot of what we do with our patients who are mechanically ventilated is reactive with whatever is happening at the time. The proactive approach of using non-invasive or some other type of intervention prior to intubation is, of course, something that maybe people don't think about all that often, maybe avoiding getting patients to that point where the only option at that time is mechanical ventilation. So when we talk about the basic results of this study, what would you recommend to respiratory therapists when they're approached from their team regarding either the silver tubes or a scraping device or both?
if the RTs have, if we have the evidence here and we've looked at all the studies, that we can, confidently say that there is no real clinical significance, and, to be able to say that one thing works better than the other. And it's not that we have to change our whole inventory or our entire practice, but we didn't find anything in this study that decreased the microbial loads. We did find a downward trend in biofilm. So looking at, keeping tubes free from biofilm or reduced biofilm, obviously, is a great thing to do. But again, we're not seeing in any of the studies any significant differences in any of, anything that we're doing currently.
Well, Donna, thank you so much for joining us today. I really appreciate you sharing your expertise and kicking off our JournalCast series with this study.
Thank you.
And thanks to everyone who joined us today. I'm glad you were with us. Happy New Year to everyone. Our next webcast is scheduled for January 30th. Mr. Tony DeWitt will join us for a presentation focused on malpractice and the respiratory therapist. We will also have a special student webcast on Thursday, February 7th. And the JournalCast series will return with the February Editor's Choice on Friday, February 15th. Thank you for joining us, and have a great day.
All right, thank you so much, everyone, for joining today, and thank you to Donna and Shauna for the presentation. In just a moment, you'll see a Submit Credit button on your screen. If you're an individual who's registered for this program, you'll go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and then select the Click Here button link. Also, you will receive an email with instructions to submit for credit should you not be able to complete via the viewer. If you're a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's presentation, and to end, simply exit out of the browser window. We hope you all have a great afternoon.